I never proceed. All right, I think we can get going. Laura?
Very good. Welcome to the Coalition on Aging's Health Equity Workgroup meeting. Today we have a guest speaker, Kimberly Strong, who is the Executive Director of Cabarrus Meals on Wheels since 2006. She holds 2 degrees, one in elementary education and also an MBA with a concentration in public administration. Kimberly has over 26 years experience working in a nonprofit setting. And a few fun facts about Kimberly. She is the president of Meals on Wheels in North Carolina, an association of senior nutrition programs in North Carolina. She is the past president of the Rotary Club of Cabarrus County from 2017 to 2018. She's also a board member on the NC Association on Aging. She's also a member of several boards and committees in Cabarrus County. She serves as a consultant to other senior nutrition programs across NC for best practices. And she has 1 adult son, Andrew, and she also lives with her husband, James, in Concord. Thank you, Kimberly, for joining us. We're really excited. So if you want to take it away.
Make sure I'm on. Okay. Everyone can hear me? And,
Yes.
All right. Good morning, everyone. Thank you for the invitation to come and speak. I want to say hello to Audrey. I see she's on there. Hey, Audrey. Nice to see you. Haven't gotten a chance to talk to you in a while, so nice to have you here.
Hi.
Good to be here.
So I am going to talk this morning. I was asked to do a little presentation on older adult food insecurity and malnutrition. I need to share my screen. So I need to have the host enable that.
It's done.
Awesome.
Yeah.
Thank you. All right. Can everyone see my screen?
Yes.
All right. Now to make sure I can do this right. Okay. So our learning objectives, we're going to distinguish between food insecurity, malnutrition, hunger, state of senior hunger in North Carolina, identify the root causes, and discuss the importance of partnerships and lessons learned. Food insecurity, as we all know, is a household level economic and social condition of limited or uncertain access to adequate food. Malnutrition, the deficiencies are imbalances in a person's intake of energy or nutrition, and hunger is prolonged involuntary lack of food, discomfort, weakness, and illness. A lot of times we know people who are malnourished may also seem to be overweight, and it's because of, we all know it's because of the incorrect food that they eat. It isn't necessarily that they're hungry, it's because of the food that they're eating. They usually tend to eat the high fat, cheaper foods, which, as we all know, makes you malnourished. Some population demographics of older adults here in North Carolina. We are ranked 9th in the total population, 8th in the population of age 65 plus. As we all are aware, population 65 plus is growing all the time. Over 60, the counties for over age 60 outnumber the counties that have the population under age 17 or 18. So we are a graying state. And a lot of that, as we know, is like people like me who move here, and then your family members come here with you. And so they're aging, and grandparents come to be with their grandchildren. 93% live in the community. 9% live below the poverty line. 43% live in single person households. 42% of the estimated grandparents are responsible for grandchildren under 18. We have seen a lot more of that here in Cabarrus County too, where the grandparents are raising their grandchildren. We get several calls for people who need meals the grandparent needs meals, I want to know if we can also provide meals for their grandchildren, which we don't do. State of senior hunger in North Carolina, unprecedented growth in our older population, and the COVID-19 pandemic has exacerbated the issues of adult food insecurity and malnutrition, increased the number of adults needing food and nutrition services, and has complicated the ability for existing programs to provide services. Again, as many of you know, the pandemic, we saw such an influx of people needing service right as the pandemic started there in 2020. We were very fortunate here. We have our own kitchen. The community stepped up. We were able to continue to serve nonstop since when the pandemic started. Recently, just in March, we have really noticed an uptake in our referrals now that the SNAP situation has changed again. People are not getting the extra SNAP benefits starting this month. So really, the very first week of the month, we just started to see a greater intake of referrals again. And we expect that to continue over the next couple of months as people start to use up their balance in their SNAP accounts that may have had extra SNAP money, and they no longer have that. Some health characteristics of older adults, 81% have at least one chronic condition, 54% have more than one, 34.5% have at least one disability, 41% have 4 or more chronic conditions. And we see that more and more and more, especially with the long COVID patients. We're really starting to see some of those effects. Social determinants of health, factors that contribute to insecurity and food insecurity and malnutrition. Poverty, we all know that's a great determinant of insecurity and malnutrition. Again, people buy the food that they can afford. And typically it's the high fat, high cholesterol, all the food that has all of the preservatives in it. Chronic health conditions, disabilities, living alone. If you live alone, a lot of times you just don't feel like making a meal for yourself. You just eat what you have. My mom is a great example of that. She lives alone, and when I go to visit her, I'm like, oh, mother, she just snacks throughout the day instead of making that meal. But she said, why do I have to make a meal for just me? So racial and ethnic minorities, food deserts, people cannot get out to where they can buy nutritious food. If you're immobile, you have chronic health conditions. Transportation, I was just going to say, and transportation is not always available. And again, the social isolation. Studies indicate a correlation between household food insecurity and a decline in functional health, which create barriers. It increases possibility of negative disease outcomes and high cost healthcare utilization. Low income older adults often face spending trade-offs that can lead to and worsen food insecurity, housing, utilities, transportation, healthcare. We see this a lot in our Meals on Wheels program. People either buy buy food or they buy their medications, they pay for their household. Most of our clients here at Cabarrus are renters. Rent, as we know, is astronomical, even for substandard housing. It is still very expensive. So everything they get, most of our clients are just survive on Social Security income. Our average Social Security fixed income client receives $1,100 a month. And then they try to stretch that throughout the month for all of their household expenses. Food insecure seniors are more likely again to have the chronic health conditions, depression, asthma, diabetes, congestive heart failure, heart attack. North Carolina has had the highest rate of older adult food insecurity in the US in 2020. that to me is such a sad statistic in our state. We have so many advantages here in North Carolina, and yet we're still 14th highest rate of older adult food insecurity. SNAP, those who are eligible, only 59% actually get them. This says our North Carolina monthly allotment is $108. Here in North Carolina, our clients, it's $20 a month. We ask that every year, or we do an annual survey, and that's part of it. And those who receive SNAP, it's $20 a month is what they get, $20. And as we all know, especially today in food inflation, $20 doesn't go very far. But the SNAP program does reduce home admission and hospitalization rates because it does give you some of that food, that nutrition. So North Carolina older adults served by the Older Americans Act. We have our congregate meal program where the senior actually goes and has lunch at a congregate site, or the home delivered meals program. And you can see some of those cost comparisons here. One meal on average across the state is almost $10. One congregate meal is about $9. A day in a hospital is $2,236, and a day in a nursing home, $240. You can see if we can just get that nutritious food to someone, it would make a difference. Now, malnutrition, which is different than food insecurity, it's under-recognized, but it's a growing health crisis for older adults in the U.S. It is a state economic burden. 50% of older adults at risk of becoming or are malnourished upon hospital admission, yet only 8% of them are actually diagnosed. Hospital nutritional interventions substantially improve patient outcomes and reduce the cost. 22% reduction in length of stay, 5% reduction in readmission rates. As we all know, those readmission rates and readmission costs are a big topic right now. We really try to reduce those readmission rates to the hospital. Some other statistics, how much it costs. Some partnerships to fight food insecurity and malnutrition. Obviously, I mentioned the Older Americans Act, the reauthorization of the Older Americans Act. Current dietary guidelines has added the older adults, and they've mentioned malnourishment for the first time. A federal panel, and then the White House Conference on Hunger, Nutrition, and Health, which was held in September of 2022. Hopefully some of you were able to join that on that day. First time in over 50 years that the White House actually held a conference on hunger and nutrition. They have some great ideas. It's, again, funding and getting that support to get those programs through. The Older Americans Act, just in case you're not familiar, I'm sure everyone is, it's a nutrition program, a federal nutrition program that supports health and well-being of older adults through nutrition services. It's a threefold reason for the OAA. It's for adults age 60 and older, with priority going towards seniors with the greatest social or economic need, including seniors who are low income, racial or ethnic minority, live in a rural community, have limited English proficiency, and are at risk. Another partner we're doing, obviously we're doing the Community Champions Week, March 20th through the 24th with North Carolina Retired Governmental Employees Association. And Daryl had just told me that there's 193 people signed up for across the state to deliver that month or that week through various programs. So we're thrilled about that. The intent of the Older Americans, I said threefold: reduce hunger, food insecurity, and malnutrition, promote well-being, and promote socialization. Some North Carolina programs, we have the Senior Nutrition Program, Congregate and Home Delivered Program, SNAP, commodities, food banks, farmers market, senior farmers market, local food policy, faith-based groups such as NCBAM, and the USDA produce prescription program. One of the newer programs here that we are doing is a hospital discharge pilot program. Meals on Wheels North Carolina has partnered with NC Cares 360. And this program is to evaluate the effectiveness of providing healthy meals to high-risk older adults age 60 after hospital discharge. This is running through September of 2024. Our target is 1,000 high-risk older adults. And what we're doing is hospital discharge planners make referrals through NC Cares 360 to Meals on Wheels North Carolina. We then, as a state association, funnel that down to the local program. The local program will provide 2 weeks of meals through 2 weeks after hospital discharge. And what we are trying to accomplish is to show that proper nutrition upon hospital discharge, immediately upon hospital discharge, will help reduce those readmission rates and readmission costs. That program started actually in August of 2022, and it's been quite successful. Senior farmers market, income requirements to be eligible, but you get access to locally grown produce, honey, herbs, increase the consumption of agricultural commodities, increases your purchasing power with SNAP. This is a great program where it's available. The seniors can get fresh produce, fresh fruits, which is something they don't often always get. Some lessons learned and some opportunities. So our hospital discharge program, we just did our first quarterly reports as of December 31st. Some of our lessons that we learned, we don't have a lot of hospital programs that are actually on the NC Cares 360 platform. If you're not familiar with NC Cares 360, it is a referral platform that many programs across the state use. Hospitals use it to make referrals to local programs. The referral process itself can be a bit convoluted. We're not sure. We've had difficulties following up with the clients after service dates. They don't always answer the phone for us, as we know. They're not exactly, and they don't have email for us a lot of times to actually email them a referral, because we like to follow up 30 days after they receive the meals to see how everything went and how everything is going. Some opportunities: raise awareness about food insecurity, bring together all kinds of businesses, work together and trying to find a solution. Strengthen our referral process, support our community partners, such as delivering for Meals on Wheels during the Community Champions Week. That's going to be great. Strengthen our SNAP for older adults. That is one thing. We try to do that SNAP outreach for our clients. Not all of them think they're available. Not everyone thinks they can qualify. So we try to get that outreach out there. Implement improvements to the discharge planning, engage in state policy. Nutrition and Aging Resource Center, it's a great place to get some resources at acl.gov. You can get all kinds of information: food security, insecurity information, consumer information, tip sheets, guides, webinars. They have a ton of information on that website. And there's my contact information. If anyone wants to get in touch with me. Questions?
Kimberly, this was excellent. So how do we, you had written down a question. How do people know about this? The people who need it?
About Meals on Wheels?
Yeah, about everything, because I'm finding that people they just don't know. They're having a hard time finding information, so they just live the way they're used to living.
So the Meals on Wheels program, every program, so there's a program in every county across the state. So there's over 100 programs here in North Carolina. Every program is run differently. Mm-hmm. So it's a difficult question to answer. Now, my program here in Cabarrus County, we do outreach to doctors, hospitals, churches. We do any kind of an expo or any kind of informational fair that's out there. We get a lot of our referrals from doctors' offices. Department of Social Services, they also do a lot of referrals, but some of the programs, obviously not everyone knows about us, even here in Cabarrus, even though we try to get out there as much as possible, still not everyone knows and knows that they qualify. A lot of times, one of the greatest detriments that we find is that people believe that Meals on Wheels programs are for only low-income seniors.
Mhm.
We are a need-based service, not income-based, meaning we're there. We don't care how much money you have or don't have. If you need a meal, we are there to serve you, and not everyone understands that. And a lot of times, it brings a derogatory feel to the program, and it should not, because we are a need-based program. But that is a great question, and just trying to get that out there. And that's where we need your help to make sure that people hear about us and know about our programs across the state.
Yes, because that is certainly, I do a lot, we do a lot of work, and that's what this committee is about. The health inequities and the food insecurity is crucial. You mentioned housing, transportation, all those social determinants just really add on top of each other.
Absolutely.
To create the situation we're in. And my organization would like to help get more information out to people. So I'll be reconnecting with you after next week.
Absolutely, absolutely. One of the programs here in Cabarrus that we do is we actually have partnered with Cabarrus Family Medicine, which is a part of Atrium Health here, and their resident doctors. So their office is literally right behind us, and their residents and their third-year residents, it's mandatory for them to come and deliver a couple times with our program, to go out into the community so that they can actually see the housing, the person's environment, where they're actually coming from. Because, and I've taken the residents out, and they say, we had no idea people actually live in like this substandard housing. They see them in the doctor's office and they have these chronic conditions. They don't understand how they actually got there. And so this actually gives them an idea of where your patient is actually coming from. So, yes. Gina, I see your hand up.
Yeah, first, sorry to be so late and to miss that presentation. But if you think it's hard for people to know about Meals on Wheels, try some one-off program in a community, that's really trying to work on equity issues. But I was just curious because, you all have contracts with DSS, so you get a lot of feeds. Just other folks, when you're implementing programs and you are trying to touch people with more limited incomes that are disproportionately people of color because of historic racism, obviously, and lots of other reasons, historic and present racism. And, we struggle with that because, providers' offices are big, pharmacists' offices are big for us. But I'm just curious, and Dick, you're so good at social media, but a lot of the people we want to serve are just, I'm sorry, they're not on Instagram. They're not looking at the TikToks and, whatever. So I'm just curious if anybody's found, we actually have Meals on Wheels of Durham distribute our materials. So we at least annually, we try to make sure that we're reaching those homebound folk. Mm-hmm. But any other sort of pearls of wisdom anybody has around reaching people, especially hard to reach folks that may be more vulnerable? Secret sauce anybody has?
We do this. We do the same thing here in Cabarrus. I'm sorry. We actually distribute, as you just said, just like Durham does. We distribute for various organizations.
Yeah, that's great.
We actually go into the communities. We have a great volunteer who, in our African American community, one of the pastors at the main church there, he delivers for us, and he's a very big supporter. Yeah. So he makes sure that all of our information is always there. My word of wisdom would be connections, and we all know that, relationships. So, yeah. Mm-hmm.
That's what I was going to say, Gina, is that not that I'm particularly good at it, but what I've learned is that faith-based organizations, especially in communities of color, are often the trusted source of information. Yeah.
Especially the older population.
Right.
They're the ones that are continuing with the continuing to attend church and may do it in person.
There was a program I heard about in South Carolina years ago about organizations partnering to educate barbers and beauticians about their services, because that was the place women would go every week and where men would get information. And I have always thought that that was really a smart way to pour into education into some champions and folks in the community.
We've done a lot of that. We've had some NCCU students around East Durham doing that. But the problem is it's just churn, it's just constant. You do it 1 year, but it's a huge person power thing to get the materials out and about. The other thing that I was thinking of is I just got my eyes checked the other day as ophthalmologists and dentists, even though we don't have Medicare benefits. I realized when I'm sitting in the waiting room, the ophthalmologist, that I'm the only one maybe under 65 in the room. So I was thinking that might be a good option too.
One person or one group early on in the pandemic that was identified as a potential connection to get COVID vaccines out was the Dollar General, because they are in so many low-income communities.
Yeah.
And that's where everyone goes for everything, right? I mean, they have everything you need, right? So that could be one thought. I don't know if you could network with someone there to leave information, but it's
I
a
just
thought.
don't know if they let you hang things. Like a lot of our grocery stores won't let us put things on bullet. I mean, they don't even have bulletin boards anymore.
Right.
It's odd.
Yeah.
So
Corporate headquarters.
the LGBT Center of Raleigh has 2 or 3 health fairs a year.
Yeah.
And everybody is invited to come and exhibit anything they want to at the health fair.
Yeah.
So I would encourage anybody to get in touch with them and find out what their schedule is. I think they have one coming up next month, actually.
Got a lot of health.
Yeah,
fairs.
we need to make sure we know that. I think Mary Stover Williams has a question. Mary, are you on, or do you want me to read it from the chat? Okay, I'll do it from the chat. She asked, can you make meals culturally inclusive?
So some programs do. I know Durham does a good job of that. It's very difficult. Most of the Meals on Wheels programs here in the state contract with a caterer. Very few. There's only a few programs in the state that actually have their own kitchens, and that would make it a little easier. But when you're trying to make meals for 500, 600, 700, 800 plus people a day, it gets a little bit difficult. But I know, like, as I said, Durham does a very good job about that. Wake has some of the different kinds of meals. But overall, the answer is not economically feasible for a lot of the programs. So, yeah. Unfortunately.
Durham actually also provides meals for pets.
Yeah, we do. Yes, many programs do that. We do the pet program here in Cabarrus County. We get donated dog and cat food, and so we deliver that out to our clients to help offset the cost of food for them. Again, we're talking about people who typically tend to be very low income. Yeah.
Yes.
I wanted to just touch base something Gina was saying a little while ago about the people aren't on social media platforms, the people that we're trying to reach. That is one of my big soapboxes, that every time you go somewhere, they're like, here's a link. Here, go to this website, go do this and go to
Our
that.
QR code. I was like, yeah.
They don't have the access. And well, why, you can teach them. They don't have internet. They can't afford internet. So I get on that. And then the whole, well, you're talking about people that don't have transportation. They don't have access to transportation because of, go somewhere. Well, they can't go somewhere. They don't have access to it. So I get on that a lot.
Yeah.
I just wanted to, sorry, go ahead.
No,
Oh,
you can go ahead.
I think the pilot program with the hospital is genius. I'm a nurse and I used to work in a hospital setting. And even today I was amazed. I mean, at that time I was amazed, like, oh, you had a knee replacement yesterday. Well, you're awake and you're breathing today, so you can go home. You're good, right? I mean, it was just, I know people are discharged from the hospital because they don't need that sort of level of care any longer, but I know that a lot of folks need additional support once they get home. So I think that is really, really cool. I'll be
Well, thank
interested to
you.
see the outcome. Yeah.
Yes, as I said, we started in August and it's going quite well, so we're excited about that. Another program that we're doing here in Cabarrus, we will start it in the fall with Cabarrus College of Health Sciences. We are partnering with them to take our most vulnerable clients, the ones that are the frequent flyers into the hospitals, and we're partnering them with various students and their various programs. And throughout the semester, they're going to visit our client, and every time they visit, they're going to like one visit will be all about nutrition, and they're going to actually go through their cupboards and the refrigerators and talk to them about the different food and nutrition. Another visit is going to be falls assessments, checking out their environments, and talk to them about that. One will be about the importance of exercise and walking and getting up and doing stuff. So we're hoping to, again, reduce some of those readmission rates and costs into the hospital. So we're looking forward to that.
That's pretty-
Did anybody, has anybody had any, I think about these communities that got the Healthy Opportunities grants, like the counties that got them. Of course, it wasn't intended for dual eligibles, right? But I'm just wondering if that's bleeding over, that you're funding, you've got source of funding for some things so you can shift some monies over to help more older adults. Does Cabarrus have the Healthy Opportunities? So you're not part of it. Is anybody in a county that has it? And have you seen that cost shifting that allows you to serve more people that are more vulnerable, but duals or older adults? I'm just curious about that, whether that's happened.
I'm in Mecklenburg. I don't know about cost shifting, but I do know that the mobile food pantries with fresh food has really grown. We have like 14 sites now that are possible because of that funding. So, and then I just wanted to add too, while we were talking about discharge planning, and meals, and it is a brilliant idea. And what, Kimberly, correct me if I'm wrong, but the beauty of what I'm hearing Meals on Wheels doing, or one of the beauties, is that because it's the Older Americans Act, you're capturing that 60 to 64 and 365 days old people that often fall through the cracks because they don't have Medicare Advantage sorts of resources that 65 plus can get to. So
Correct.
that's
Yes.
great. Yeah.
Yes, it is age 60 and up. In our program here in Cabarrus, we actually do under age 60 if you're disabled. So we actually have quite a few people who are under age 60.
I'll add here, I guess it was last week, there was a presentation of the Joint Appropriations of Health and Human Services Committee, and they went over the Division of Aging and Adult Services budget and showcased where spending in the Home and Community Care Block Grant was, which is those Older Americans Act. And nutrition programs are overwhelmingly more than 75% of the funds are spent on congregate nutrition services. And the current waiting list is over 7,000 for those two programs alone. And so, by and large, the monies are going to those programs, but the demand is still there, even with the ARPA dollars and the infusion of those federal sort of COVID dollars that came to North Carolina. And so there's this impending cliff when those dollars, we've added people to services, but those dollars are going to end. So in essence, there are people who are getting Meals on Wheels who could be, taken off the list in 2024.
That's what I was going to say, Heather. We had that influx of all those stimulus funds that came in for senior nutrition. Incredibly grateful because we all had seen such an increase. But what's going to happen? The question now becomes what happens when those federal dollars are gone, and we have all these people on our rolls. So it's a scary prospect of what we're going to see happen. It's like what we're seeing happen now when the SNAP extras are ending. And we're seeing such an influx of people who are needing food. So it's come September 30th or October 1st of 2024, we'll see what happens.
I've got another question. I'm sorry. This is supposed to be a group working on race or equity, right? So just related, you just mentioned SNAP. One of the things that I find people, and like I think of Medicare savings programs, help with MQB, low income subsidy with Part D. A lot of these programs, people's income is plenty low. It's just their assets are just, and you can own a home, you can own a car, but I mean cash assets. You as an individual, you save $20,000 for a nest egg, $40,000. You're not eligible for anything. I mean, you're cut at the knees for most things. So I'm just curious. That's our experience, but I never hear that. And by the way, states have a lot of flexibility in being able to change their assets test, especially with Medicare savings plans. Some of them $100,000 if you look at what other states are doing. We can have a lot more people, and that would be cash in their pockets to pay for Meals on Wheels or to contribute to, the services that they receive. So it gives money to people, who are eligible by changing the assets test. Do you all find that with a lot of the plans that are supposed to be helping people? You've got to be the right person. You got to have the right income, Do you find that assets are often a barrier to eligibility for federal programs?
We have seen it. I've seen it actually personally with my mom and trying to get her some assistance.
Yeah.
She actually lives in New York State, which they have, like you just said, every state has such different varying rules. When I was trying to help her, I was so confused because I know our rules here, it's out in North Carolina. And I'm like, but that's not, and then I kept being told, well, that's not how it works here in New York. So yes, it is extremely difficult and it makes it hard because you either are supposed to have money to help yourself or you have nothing.
Yeah.
And so
I think the SNAP assets test is 2,000, just like the Medicaid is 2,000 for a single and 3,000 for a couple. I think it's somewhere near that. It's super low, maybe even worse than that.
So in New York State, they have a programs because my mother had actually too much income. She's just on a fixed income Social Security, but it was too much to qualify for Medicaid. We were trying to get her dual eligible. She had a massive stroke and like $200,000 hospital bill. I mean, it was absurd. So we were trying to get her dual eligible, and they said she had too much money coming in Social Security. But New York State has a program where, and I'm not sure how they do this, but she takes what is over the limit every month and it gets sent to a trust. And that trust then pays for everything, all of her expenses out of that trust. And because she does that, it makes her eligible to become dual eligible. So
we have that. I think that's what we would call the spin down.
Yeah, it's a spend down.
Yeah, but it's brief. It doesn't stay with you, but it at least pays that medical bill and makes you eligible for a short period of time.
Exactly, and that's what we were trying to do. So yeah,
a lot of people in nursing homes in North Carolina, that's exactly what happens. They go through this. They just stay on Medicaid because they have to constantly go through that spin down process.
Yeah.
I think it's interesting just because Meals on Wheels are in so many communities, so many low income communities where serving people who are isolated. And sometimes I think of you guys as a front line to a lot of these public benefit questions. And it makes me think about the unwinding of the public health emergency and, when people are going to be, or redetermination of Medicaid just on any day with people when they get letters in the mail that they don't understand and they know Meals on Wheels is going to be there every day to deliver a meal. Or, you guys have that trusted relationship with individuals where they come to you with a lot of questions and it's not just a meal all the time.
It is not, as I said, we do the pet food program and so many different programs, but absolutely, we get calls about everything. We had, they have a problem with their bank. They call us and asking us, and we're like, we don't know. You need to call, Wells Fargo. We had someone. But any kind of situation. And then several years ago, it was before the pandemic, and they were doing the budget, and Meals on Wheels came up in that budget process and how it was going to be defunded, and which was, it wasn't, but it was on the news and so forth. And oh my goodness, that was just everyone calling, you're not going to be able to bring us a meal and this and that. And they were so scared and they were so nervous. And even with the pandemic, we were their first line of that, as Heather said, the frontline people. We were the ones that they were talking to about it. We were the ones that came to, because we were still there every day and they saw our people and they knew that we were going to be able to hopefully answer questions for them. So yes, we are so much more than just that meal.
Yeah, I was wondering, I think probably one of the best assets of your service is that you actually touch somebody every day in their home. But that brings up another issue. If there are people going to these folks' homes, are your volunteers trained in diversity and inclusion? Because I'm just wondering if there are people who don't want to be in certain people's homes, or there are certain people who don't want other people coming into their homes.
We do not have that issue. Not that we're aware of. I mean, I've never had that kind of a problem arise, thank goodness. Usually our clients are so grateful to have anyone come and visit them or bring them a meal. I don't know about other programs though.
Some of them are, I've been finding out as I've worked with several of the organizations to work on the Champion Week, and they're all over the place list. Some require background checks, some require hour-long training, some require nothing, so it's kind of all over the place. I think that may be one thing that we might talk about in this group, to look at how we pull all of these entities together to ensure that we have a better coordinated effort that's inclusive of all the various populations, so that we can do better than we are, even though we're doing great. It's always a step, we can always go a step further. And I think that's what we need to do. I think that'd be a great topic for us to, circle back around to, and see how we can all kind of coordinate our efforts and look at how we can work to ensure that we have inclusivity included through that lens.
Well, that's one of the goals. That's one of our recommendations moving forward.
Absolutely.
Is that kind of training become necessary and expected, that is part of the, not adjunct to anything that we do. Kimberly, I'd like to thank you so much.
Absolutely.
For
Thank
being
you.
with us today. This has been, we could spend like days on this. So you need to be part of this.
Well, thank you so much. This has been great. I appreciate the opportunity. And Daryl, I'll see you soon. I'll see you Monday.
Monday. Thank you.
Monday.
So
Thank
much.
you, everyone. Have a great day.
Take care. Thank you. Thank you all too for all the questions and the participation this morning. So definitely food insecurity is one of the social determinants of health. And look at how many things just by itself it affects. So, we have a lot of work to do. All right. So I guess we need to transition to the second part of the meeting, so that we have about 10 more minutes, even though we may take a little bit longer. And if you have any more questions for Kimberly, we just need to bring her back. We can talk about that, or we can send the questions to her so she can get the answers back to us. All right.